This is the second, in fact, of three science panel disseminations of the conclusions of our work on probable links. And myself, I've met you all before, I'm Tony Fletcher, Dr. Kyle Steenland, Dr. David Savage, the three members of the panel. We're all here, and we will be able to answer any questions arising. We planned to do a short summary of the key results and the reasonings for the conclusions we've reached. Now, I shall speak first, and then Kyle Steenland will carry on. And who's operating the computer? No? Next slide. So, as you know, the main function of the C8 science panel is to determine whether or not there is a probable link between a number of diseases and exposure to PFOA or C8. Let's go down a little bit. And the probable link, as you know, is whether or not it is more probable than not that a connection is found, in our opinion, between C8 and specific disease. Quite a small room, so we don't need it so loud. And we have, in order to reach this judgment, we have had to invest quite a lot of effort into collecting more information, following up the important baseline data created by Brookmar in the C8 Health Project. And we're going to present some of the key results on which we base the findings, and then the conclusions. Next slide. And in particular, there's three studies that are just reaching completion, and we can use the results for those for our evaluations. And they have not yet been disseminated, so today is not only the presentation of the probable link conclusions, but also key results that have come out of these three different studies. One is an analysis of geographic patterns of cancer incidence. Second is looking at the prevalence, the pre-existing cancers in the C8 Health Project data. And the third is following up over time the cancer incidence in that same population. And we'll summarize them briefly in turn. Next slide. The geographic cancer study has drawn on information provided by the health departments in 13 counties, covering the area of the C8 Health Project and neighboring clean areas, using registered cancers supplied by the state health departments in Ohio and in West Virginia. Next slide. And this, one can't see all the outlines, but this shows the county boundaries for the non-exposed counties, the 6 water districts that we'll know about, from Little Hocking down to Mason County. And you'll notice that there is a slightly wiggly boundary on these water districts. This reflects the big effort that we've made to determine exactly how the pipe network, and therefore the potential exposure from the water supply, has reached the population, so that we can accurately assign either the population in small census areas or the cases we've identified in the various studies to the right exposure grouping. Next slide. And essentially, we compare to see whether the cancer risks vary between the non-exposed and the exposed, and within the exposed to do with degree of exposure, again depending on allocating the address where people were living at the time of diagnosis to these different exposure groups. And from the detailed data we got from the state cancer registries, we could categorize them into 18 categories of cancer. And you'll be pleased to know I'm not going to present 18 slides for every single category of cancer, but focus in on the 2 that showed some suggestion of an effect, which was testicular and kidney. And we got a little bit of an effect for prostate, but I'll focus on the testicular and kidney results. Next slide, please. The testicular cancer, and this is summarized in the press release in more detail, but the key finding is that there was a trend across increasing exposure groups, going from 3 to 6-fold. We analyzed them in a couple of different ways, but the different analyses showed a consistent excess, which is that the highest exposure group, highest exposure group showed the apparently highest risk of testicular cancer, and this trended from low up to high. One needs to remember this is a relatively rare disease, so it was based on a small number of cases, but nevertheless it was what we call statistically significant. Next slide. For kidney, there was a similar pattern, although the sizes of the relative risk were somewhat smaller, but there were still some significant excesses, and a trend with increasing risk by increasing exposure by whether you categorize them by exposure groups or by water district. Next slide. Finally, I mentioned that we reanalyzed the prevalent cancers in the C8 Health Project database, and we were comparing that to the measured C8 values in the rather than historical modeled exposures, but the measured C8 values at the time of the C8 Health Project. Because that was a measurement done in one fixed point in time, we focused in on recent cancers in the 10 years leading up to that survey date. And again, checking through all the different cancers where there was sufficient numbers to find an effect. And the only one that showed a signal, and it was kind of weak, but reaching statistical significance, was for prostate cancer, where there was a trend going up to a 1.7-fold higher risk in the highest versus the lowest group. That was not confirmed in the geographic analysis I've just presented. And with that, I'm going to hand over to my colleague, Carl Stephen.
Thanks, Tony. So Tony's presented two new studies, the geographical study that you saw comparing the sort of exposed areas to non-exposed areas using cancer registry data, and the study of cancer prevalence in 2005-2006 conducted by Brookmar on the C8 Health Project. And then the third piece is what we call the cohort study, and it's a study of 28,000 community residents and 4,000 workers at the DuPont plant that we were able to interview in 2009 and 2011. We collected medical history at that time, and we found out where they lived, and that we had already gotten some of that data from the C8 Health Project. We filled in the gaps that were missing and made a complete residential history, which we used to estimate what people were exposed to a long time ago in the past, coupled with the emissions data from the DuPont plant and the residential history, putting those together to try and figure out what the blood levels were of C8 in people over time, and particularly in 32,000 people over time. Next slide. So about half of these participants reported some sort of disease, and we went out and found their medical records when they gave us permission to, and we also matched their data with the Ohio and West Virginia Cancer Registry, all of which was trying to confirm what they told us from a medical record. It's sometimes difficult for people to remember what a doctor told them, or a variety of reasons why someone might report a disease that they might have a confusion about which organ was involved, what the disease was, and so we always want to confirm by medical records what the doctor thought they had as well. So that's why we went to that effort, and that was actually a huge effort. That took many years, as you can imagine. You're talking about finding 15,000 medical records and in a variety of hospitals and doctors' offices. So we got that data, and then we, as I mentioned, we estimated the levels of C8 in the blood over time for these 32,000 people, and we kind of added them together. So the idea being that the total amount you've had in the body over time is the most relevant for predicting disease risk. And then we analyzed the data to compare the rate of disease occurrence in those with high blood levels of C8 versus those with low blood levels. So that we're particularly interested in what was the level of C8 over time before you were diagnosed with a certain disease. the kidney cancer rate in the, so we divided the population into 4 parts based on how much C8 they had in their blood over time. We call these 4 divisions quartiles. And the kidney cancer rate in the upper 3 quartiles is compared to the lowest one. The rate of kidney cancer was 20%, 40%, 60% higher in the upper quartile, 2nd, 3rd, and 4th, compared to the lowest, based on 133 confirmed cases. For testicular cancer, the corresponding numbers were higher, 80%, 120%, 170% higher for the upper quartiles compared to the lowest. Based on a small number of cases, only 19, so that makes the findings perhaps a little less reliable, but the trend of increase is quite strong in these data across the quartiles. Yep. Finally, in the same cohort study, we looked at adult onset diabetes, which is much more common, of course, than these rare cancers. 4,800 study subjects, a quarter of the population, a little bit under that, reported having type 2 adult onset diabetes, for whom medical record confirmation was obtained for the great majority, almost 3,900 there. So we did the analysis on the 3,900, and I should say that adult onset diabetes is the great majority of diabetes, perhaps 90 to 95%, with the remainder being juvenile onset or type 1 diabetes, which occurs in young people, which is a different disease, an autoimmune disorder with different causes. So we will be analyzing the type 1 or juvenile onset diabetes separately, and we'll report on that in late July. Here we had a lot more cases, so instead of using quartiles, we divided the population by exposure groups into 10 exposure groups, according to increasing levels of C8 exposure, again, always before disease occurrence. There was no positive trend in diabetes occurrence by these categories. All categories had about the same rate of diabetes. So for us, this was fairly strong evidence there was not an effect, but we'll get to that in a minute. Yeah. So when we had to put this together, we put together the cohort study, we put together the geographical study of cancer that Tony reported on. We took together the study of prevalent cancers at the time of the C8 Health Project. Put those together, and we put them together with any other data that was out there, including, say, a cohort mortality study that we did at DuPont, for example, of the workers, and other people's reports from not only Mid-Ohio Valley, but the rest of the world. So we had to put all the evidence together and come up with some conclusion. And basically, we're trying to find out whether those who had more exposure had more disease. You want to exclude random error, so small sample size can cause you to see something that might not be real. We wanted to control for other causes of disease. For example, smoking causes some diseases. Obesity might be a problem. So in all these analyses, we controlled or adjusted for things like age and gender and smoking, for example. We considered limitations of study design. Some studies are inherently better for detecting a real relationship between disease and exposure than other designs. And biological plausibility was also important if we had some evidence that some exposure, that C8 exposure was linked to some disease based on either animal studies or plausible mechanisms that might also be relevant. In the end, we had to follow the charge of the court, which is it more probable than not that C8 or PFOA exposure is causing a disease rather than a chance or error. Yeah. So for cancer, the analyses of medically confirmed kidney cancer in the cohort study showed higher rates than those with more C8 in higher rates for those with more C8 in their blood over time, a trend which was unlikely to be due to either chance or bias. And that was supported by two things. One, in the cohort mortality study of workers at the Washington Works plant, we saw a higher trend of kidney cancer among workers with higher estimated exposure over time in the plant. Based on very small numbers, there were only 12 kidney cancer deaths in that analysis. But kidney cancer deaths are much less common than kidney cancer occurrence because people survive and don't die necessarily of kidney cancer. So the cohort study had 113 validated cases, which are obviously much bigger numbers. And secondly, the geographical study of cancer occurrence that Tony described also showed some signal of an increased trend of kidney cancer occurrence in relation to C8 exposure. It should be noted there's some overlap of cases in these two studies because the cohort, of course, lives in the geographical area, and so some of the cases overlap, but not all of them. Okay. So in the end, taking that together, we conclude there's a probable link between kidney cancer and C8 exposure in the Mid-Ohio Valley. Okay. Regarding testicular cancer, analyses of medically confirmed testicular cancer in the cohort study again showed higher rates, those with more C8 exposure in their blood over time. There were few cancer cases, testicular cancer cases. Nonetheless, the trend was quite strong of increased risk with increased exposure, and we don't think that trend was due to chance or bias either. We have some other supportive evidence C8 causes testicular cancer in animals, and a geographical study that we talked about also provides some supportive evidence by finding consistently a higher rate of testicular cancer in those with more exposure. And again, there's some overlap of cases between that study and the cohort study, but not a complete overlap either. So, taking these evidence together, we conclude there's a probable link between testicular cancer and C8 exposure in the Mid-Ohio Valley. Regarding the 19 other categories of cancer we examined, we did not see evidence to support a probable link with C8, and they're listed there. There's limitations in what we could do that should be recognized. We have few numbers of cancer cases for a number of things such as liver cancer and pancreas cancer, which are very fatal, which are relevant to the animal evidence because there's animal evidence for those cancers, and yet we had limited ability to detect such relationships. But in the end, we can't conclude any probable link for any of these 19 other cancer categories. Yeah. On diabetes, as I mentioned, there was in the cohort study no indication of increased risk of adult onset diabetes with increased C8 based on a large number of medically confirmed cases. There was evidence of increased death from diabetes in 2 occupational mortality studies based on small numbers, on the order of 20 deaths from diabetes in each one, compared with 4,000 in the incidence of diabetes cohort study. Next. There's 2 occupational studies that found an effect with diabetes mortality. It should be mentioned that diabetes mortality is not a good way to study diabetes because very few people die of diabetes. And so what shows up on the death certificate as underlying cause has a lot to do with how people code death certificates in particular areas. So it's not as reliable as incidence data, what we call occurrence data of new diabetes. And also, we did do an analysis in the Washington Works plan of diabetes, looking at, and again, the numbers were small, but looking at whether there was a trend of risk with increasing exposure. That's what we call an internal analysis, and there wasn't. So, anyway, taking all that together, we conclude there's no probable link between adult onset diabetes and C8 in the Mid-Ohio Valley. Yeah. So where are we going from here? We did we had a probable link judgment on reproductive outcomes in December, and today we have done that for cancer and adult onset diabetes. And our plan is to complete the remaining diseases by the end of July of this year. So that's it.